We are now.
Perfect. Great. Well, welcome everyone. I'm delighted to welcome you on this a little bit of a cloudy and cold day here on the University of Washington to our first Big Heart Seminar of our 2022-2023 academic year. As we start, I want to start us off, especially on as we do with all our seminars and acknowledging Native American Heritage Month, our land acknowledgement at the University of Washington, that we learn, teach, live on or near the ancestral homelands of the Coast Salish peoples whose ancestors have resided here since time immemorial. Specifically, the UW Seattle campus, where I'm situated and Marcus is situated, is on the traditional territory of the Duwamish people. The Coast Salish peoples and many other indigenous peoples continue to thrive in these lands and are alive and strong. And so we're really excited to have our speaker today, and I'll introduce him in just a moment. But first, I want to tell you a little bit about the Big Heart program and the Big Heart team. So my name is Jen Balkus. I use she, her pronouns. I'm an epidemiologist in our School of Public Health, and I co-direct this program, which is in its second year, with Dr. Karina Walters. Unfortunately, Karina was not able to attend today, but she's been a fantastic collaborator and leader in this space for quite some time. She's a leader in their School of Social Work, as well as our Indigenous Wellness Research Center, and has been working in the field of HIV and AIDS for many, many decades. In addition to the Big Heart program, Karina also works on another program called HART, which supports the career mentorship and development of postdocs and early stage investigators. And as well, we have Marcus Conde, our fantastic program manager, who has joined us this year, who is a pivotal member of our team and has been in contact with many of you in terms of setting up seminars and lots of engagement going forward. So Big Heart is actually now in its second year, and the goal of the program is to create opportunities for meetings and mentorships for undergraduate and graduate students who are of Indigenous identities. And particularly, we want to allow spaces so scholars who might be interested in pursuing a career in HIV research are exposed to what's happening in the field and other Indigenous researchers currently working in the field. So the seminar series is one of the many opportunities that we have for students and scholars to learn more about what's happening and to potentially facilitate connections. The seminar series is open to anyone interested in HIV research, but the mentorship and other networking opportunities are specific to our Indigenous scholars. In addition, we have established a program called the Big Heart Fellows Program, and Marcus is going to put the link to that in the chat. So if you're an Indigenous undergraduate or graduate student interested in learning more about this, we have more information there for you. And our scholars, or excuse me, our fellows or individuals who attend multiple sessions of the seminar series will have additional opportunities for mentorship, for networking, and as well as to attend the UW annual Principles of an STI and HIV Research course. So our series is a monthly series, with our first one kicking off here just in time for World AIDS Day. The next dates we have there on the schedule, and you can find more on that on the links online. And we're just finalizing our last few sessions for the year. We have some really exciting and great speakers. In addition, if you're interested in some of the series that was sessions that occurred last year, we have those recorded and posted. And each time we have a session, we know that there's individuals with competing class demands, clinical demands, all sorts of things that might make it a little bit challenging for all of us to be in the same place at the same time. So we record these sessions. So feel free to review these later as well if it works better for your schedule. In addition, one of the things that we're expanding to this year is a Mentoring the Mentors series. So our first series, we're just putting the final pieces together, and we're hoping to launch that in December. And we'll focus on different aspects of how to support non-Indigenous folks that are working in the HIV space to better support Indigenous scholars at various levels. So more on that coming soon. And excitingly, we're now on social media. Marcus has done a fantastic job setting up our Big Heart Instagram site, where you can find more information about upcoming speakers and opportunities. So feel free to give us a follow. As I mentioned, we're kicking off our first session here just the day before World AIDS Day. And for folks who are in the greater Seattle area, we wanted to just acknowledge a few events that are happening both tomorrow afternoon. Virtually, they're both at the same time, but they're both excellent events And I believe the first event there, this part of the HART Seminar series, is also recorded. This is a talk by Dr. Natalie Crawford on structural pharmacy-based interventions to reduce racial inequities in HIV. And then the 19th annual Stronger Together World AIDS Day meeting that's hosted by Seattle's LGBTQ Center, formerly Gay City. So we'll be able to share these slides afterwards. And I think Marcus can also post those links in the chat as well for folks that are interested and can connect to those events further. Okay, so enough from me, and I'm thrilled here to welcome Dr. Matthew Town to our session here today. Dr. Town is a faculty member in the School of Social Work at Portland State University, and we're so delighted. I'm not going to do any more of an introduction because I'll let him talk about his work, and I'm really delighted to have him in this space and to hear about risk and resilience, stories of pre-exposure prophylaxis use among Native LGBTQ people. So let me stop sharing here. And Dr. Town, I'll turn it over to you.
Great, thank you. Let me pull up my slides really quick before we get going. One second. Okay, let me try that again. Can everyone see my slides, or is everyone seeing the notes and everything on my slides?
No, I'm seeing that you're started to share, but it's that black screen.
Okay.
The slides. Do you have a dual monitor thing?
I do.
I wonder if sometimes.
Like this. Sorry about this, friends.
It's okay. Three years into this, I have still yet to master the dual monitor setup. So
How's that?
I'm
Better?
still seeing the same. It says you're sharing, but not seeing the slides.
Yes. If it's still doing that, I can go ahead and share your slides from
If you
my
wouldn't
end.
mind, that would
Yeah.
be great, Marcus. Yeah, I've not figured that out yet. Okay, this
Okay.
looks more promising.
There we go.
Perfect. All right. Well, that being said, good afternoon to everyone. My name is Matthew Town. I am a citizen of the Choctaw Nation of Oklahoma. I'm also a descendant of Yakima and Cowlitz Nations in Washington State. As mentioned, I'm a professor at the Portland State University in the School of Social Work. Interestingly enough, my background is not in social work. It's actually in public health and sociology. So I really come to this as not just an Indigenous scholar, but as a social scientist, and really excited to present some work that is kind of a labor of love, if you will. I often refer to this as my COVID project, and we'll talk a little bit about what that looks like here in a second. But Marcus, if you would go to the next screen. As we get going, I'd actually like to do my Yalkoki or my thank you acknowledgement slide first. And with this, there was a number of individuals, a number of teams that were really responsible for making this project happen. It wasn't just me in a vacuum, as we all kind of know through research. And so I'd like to specifically thank the HART team at UW and the National Institute of Mental Health, who believed in this project as I was really developing it. This project is a result of my participation in the HART project and part of that team. I'd also like to thank my project team, Martina John, Natalie Lau, Alex Looney, and Dallas Schaefer. They are my student assistants. This project was born at my previous institution and then transferred with me as I came to Portland State. So I have students at both institutions that I'd like to acknowledge and just appreciate their willingness to participate and be a part of the project team. I'd like to thank all the participants who shared their stories with us, as well as the LGBTQ Native and Two-Spirit people who paved the way ahead of us, and those that go unnamed. Your guidance and support do not go unnoticed, and you're thought of regularly. If you go to the next slide, Marcus. So this project is about pre-exposure prophylaxis. But before we get really into that, it's important to note that HIV infection for American and Alaska Native people has been on the rise since about 2014. We know that pre-exposure prophylaxis, which I'll refer to as PrEP for the rest of today's session, is one of the most promising biomedical interventions that we have. It has a lot of potential to help end the HIV epidemic, but really, in its essence, reduce the incidence of HIV infection amongst those who are not currently living with HIV. This is championed by public health officials from all over, not just the United States, but globally as well, as one of the best tools for combating HIV. If you would go to the next slide, please. But with the advent of pre-exposure prophylaxis interventions comes this notion of stigma. And with that, I'll spend a little bit of time here because it's talked about a lot in the rest of the project, is this notion that people who use PrEP are stereotyped as being sexually irresponsible, promiscuous, immoral. In fact, some of the participants in the study even referred to the stigma of just being known as a slut or a whore or all the other kinds of language that's out there and being really cast into this group of undesirables. And as a result, there's stigma or shame that come with that. And these intersecting forms of stigma may also be influenced by a whole host of other things. People don't just experience stigma of one thing, but maybe of many things. And this stigma across social groups and within social groups can hinder PrEP use, PrEP initiation and use, I guess is a good thing to say here. And so we'll talk more about that as we get going, but it's also important to acknowledge that PrEP implementation strategies really focus on high, quote unquote, high risk populations or groups. And as a result of that, people are also stigmatized for being in one of these groups. Predominantly, we talk about men who have sex with men. We talk about persons who inject drugs and persons who are at high risk for HIV. And again, just being in those categories also comes with a stigma or a shame. And then to add on top of that, this notion of PrEP stigma or shame because you're a consumer of PrEP. Next slide, please. And so knowing those things, I'm really interested in understanding kind of PrEP use amongst Native people, and specifically Native people who identify as sexual or gender minorities or Two-Spirit. And so I'm really interested in the effectiveness of PrEP in preventing HIV transmission, right? But it's also important to know that people have to be not only aware of what's going on, but they have to be able to use it to take it up, to initiate use, and then sustain use over time. And despite our best effort to provide PrEP, disparities still exist in its initiation and use amongst sexual and gender minority folks specifically, but people who live at those intersections. And today I'm going to talk a little bit about Native LGBT groups specifically. Next slide, please. So with this project, we called Native Access. It was a little call to arms, if you will, we put out with the project team, and we kind of came up with this notion of Native Access. And it's, again, a National Institute of Minority Health, Mental Health, funded project to work with Native LGBTQ communities to really understand PrEP initiation and sustained use. The motivations for the project were aimed at understanding PrEP use kind of broadly. There wasn't very much in the literature about PrEP and its use among Native people, anecdotal stories and other things, but we really wanted to take time to investigate the stories of Native people and their understanding, their awareness and use of PrEP. Today, we'll be discussing primarily those who are on PrEP. We actually found a lot of people who were using PrEP that we weren't anticipating finding throughout this project. And lastly, we want to, one of the motivations was to look at this notion of community resilience or collective resiliency that identifies and builds on individual and community strengths, rather than focusing primarily on identifying and overcoming deficits. As I'm moving forward and working more with community, we're really focusing on a strength-based or an asset-driven modeling kind of framework. Next slide, please. So a brief overview of the methodology used for this project. We used an online screener to recruit a sample, and our sample had to be individuals over the age of 17. They could identify any kind of gender identity or performance. They needed to identify as an American Indian Alaska Native person. We initially had it out for men of sex with men and or trans community, and it really stayed within that. There wasn't a lot of folks outside of those identifiers. And then we also were interested in their, I guess, sex with other men in this particular case, looking at behavioral risk factor for HIV. Participants, again, were recruited through an online screener where we kind of verified those inclusion criteria. And we really had an interesting time working on recruitment. The students really took kind of to the winds with this and did an online recruitment, looking at Native organizations, the epicenter folks, as well as other kind of known listservs. We did some targeted recruitment, but we really primarily used a lot of the network through the Two-Spirit Facebook pages, and went from there. We conducted semi-structured qualitative in-depth interviews using Zoom technology, and these interviews lasted about an hour. There was a few that went almost 2 hours, and there were some that went about 30 minutes, but on average, they lasted about an hour. And interviews were recorded and transcribed verbatim. We use a consensus analysis methodology to do our analysis, which is still ongoing. So we're looking at preliminary results today. And it was myself and 2 research assistants, which actually I should change the slide. It's actually up to 4, as I'm still including the students I talked about initially. There's 4 of them. Next slide, please. The interviews, we had 51 people who completed the screener. We probably had another 50 or so screeners that were initiated but never actually completed. Of the 51 completed screeners, we had 32 eligible participants, of which 19 completed interviews. We did reach out to those who were eligible several times, but to no avail. The people who responded back completed interviews. There were 19 of them. As I mentioned, this was my COVID project. And so with that, we launched it at the very beginning of March 2020, right before the universe seemed to close down. And we did a number of interviews those first couple of months. And then it really just kind of trailed off, which makes sense. People were very much experiencing Zoom fatigue and a whole host of other changes in their life. And we picked our project back up in December of 2021 and finalized and finished the last of the interviews in February of this year. Participant age range, because there's so few of them, I don't want to give too many of the details away as to not identify folks, but age range from mid-20s to mid-60s. The majority identified as cis men, when the rest, and I would say the rest is probably about 2 or 3 folks identified as transgender. And education and income varied with large ranges. We had people who had not completed high school to people who were on their way to medical school. And income varied from people who were not working but living with others who had income. And so they personally had no income, but their household income was decent, to others who were making well into the 6 figures. So it was a very large range of different people. A various number of tribal affiliations were also represented, and we went coast to coast and north and south. We were kind of all over the United States, which was a pleasant surprise as we were conducting these interviews. Next slide, please. So here we get into some of the content of the interviews, and this particular slide sets the stage, and I'll go ahead and read these as well. for folks. But this one really sets the stage for really understanding risk and how people are internalizing risk and assessing risk on their own. And this particular quote says, I used to have these scenarios in my head where if I got HIV, I'd probably kill myself. I would probably collect narcotics and get myself an infusion and die. And that's the kind of way I lived when I was young, by questioning person. And again, I bring this up because it is dramatic, it's a dramatic effect, but I also want to talk about the fact that these are individuals living in our communities. These are people who are related to us in some way, shape, or form, and in experiencing this. I will say this person is much older now, and this was reflecting to when they were much younger, probably in their 20s and maybe even 30s. These were the kinds of things that they were thinking about back then. Next slide, please. And so I talk about those kinds of risks because when we did these interviews, we really talked about barriers and facilitators, or the things that helped and the things that got in the way, and that kind of thing. And risk really came up for everyone. And it really came up initially, and then it kind of moved away into this facilitators, and people really began to talk more around facilitation than they did barriers, whether we're talking about PrEP initiation, which is the current slide, or perfect right here, or when we talk about sustained use, which will come up later. But a quick overview of some of the barriers, and these are things we've seen in the literature as well. People were afraid of side effects of the medication. Taking a pill every day seemed to be more of a nuisance as opposed to a barrier. It's just one of those things you have to remember. People did talk about stigma and shame of being on PrEP, or being even known to be someone who would need to be on PrEP. Again, that stereotype of who's on PrEP. The bureaucracy of going through insurance coverage and cost was always coming up. Though, interestingly enough, as the project moved forward, in the later interviews, the ones we did more recently, that came up much, much less, where it was much more of an issue for those who we interviewed much earlier on back in 2020. Uninformed providers, we'll talk about in a little bit. With respect to facilitators, people really wanted to reduce their risk. It was something that was on their mind, that HIV and this looming risk of HIV was on their mind. And it was one of the drivers or the motivators to get people in to begin to have questions with their provider around starting up and using PrEP. We talked a lot about having some sort of social support, which goes in kind of tandem with this relationship with providers. And here, there's some people talked about having Indigenous providers or being at an Indigenous facility. Some talked about being at a gay provider, or having a gay provider, excuse me, or being at a clinic that was known to cater to being gay. But interestingly enough, none of them really met that intersection. And so hopefully we can get into that, or maybe there's some questions later that come up with that. And then a lot of folks talked about advocacy in terms of educating providers, but also in terms of utilizing PrEP as a form of advocacy, as a form of resistance or resiliency, to protect not only themselves, but the community of people that they engage with. Next slide, please. Another quote says, in a rural reservation, it was me, they're educating providers. I even said, I'm gonna ask that we see each other every 3 months now to my provider about all the labs in order to be on track, because he didn't know about that. So this goes with this notion of uninformed providers who just were not aware at the time. And this is a common theme that comes up regularly, where a lot of the initiation would come up on the end of the user as opposed to the end of the provider. And so I want to take a second too to think through and acknowledge and honor some of the motivations of the participants, because I think it takes a lot from a person to go into their provider, particularly in a rural reservation area, and basically help educate them, to help inform them, and to advocate for oneself to do this. It takes a lot of strength. It takes a lot of a personal kind of know-how to do these kinds of things. I don't know if this is something that everyone would be able to do, to walk into a clinic and have this kind of conversation with people. Next slide, please. Here in talking about relationships with providers, this participant said, quote, "I called up my provider and I said, listen, we have a trusted relationship and I want to set up an appointment with you to talk about PrEP. I guess I was naive, but because I was coming from the West Coast, from an urban space, they hadn't really heard about PrEP. So again, some education kind of work, but also this idea of developing relationship and being in relationship with one's provider to begin to have a conversation about PrEP initiation and sustained use." Next slide, please. And going on that same theme, this one being a little bit longer, quote, "The provider I was seeing moved and she was like, I really want to recommend you see one of our other providers. He has been working here for a while." And I was like, well, I want to go on PrEP, but I don't have insurance and I just can't commit to paying. So I'm just going to take the risk and be mindful of my sexual exposure. And one day he calls me and he's like, "I want you to come in and get tested. I found a program through DHS. You can get PrEP for free." In this particular case, as opposed to the patient calling the provider, this is in fact a conversation that happened in which an unknown provider was working on behalf of the patient before they were even a patient, found a program that would work, and then called up the patient. So again, this relationship kind of going both ways between this person and the person previously in the previous slide. This idea where you have a relationship with the provider, the clinic, to be able to just set up a conversation and then begin the process of getting on PrEP was, I think, really a common theme, one that came across with the number of people that we talked about who were using PrEP, which was the majority of our interviews. But everyone seemed to have this story as about how did you get on PrEP, and it wasn't like it just kind of fell out of the sky or you just went in and said, here's the deal. It seemed with the people we were working with that there needed to be some sort of conversation about what is it, how does it work, and here's what the visits are about. Here's my scenario. I can't afford it. I can't afford it. Here are some of the issues I have in working with the clinic. So it's really quite, it's been fascinating to listen to these stories about how it worked. Next slide, please. When thinking about sustained use, a lot of the barriers and facilitators came up to be similar, which we didn't necessarily not expect. It was kind of expected to be this way. But again, we see things about side effects. There were several individuals, and I don't want to call out people who are older, but there was a lot of folks in our study who were also taking medication for other comorbid conditions. And so they were worried about side effects of the medication, but they were also worried about interactions, medication interactions here. Again, bureaucracy, lapse of coverage, people switching jobs or moving around became an issue around getting coverage and not being able to afford it. Again, amongst those specifically in the earlier phases of the project. And then systems navigation became quite a thing. Again, thinking about moving and changing providers. Facilitators, again, this notion of wanting to be at reduced risk for HIV infection and wanting to be mindful of kind of personal agency. These are things I can do for me. We talked about tools. I think nearly everyone mentioned the notion of some sort of reminder or application on their phone, as well as a pillbox. And this notion of PrEP buddies, which we're going to talk about here. But again, looking at PrEP use as advocacy, it's, I think, one of the really big, strong themes that came out of a lot of this work. Next slide, please. Great. So thinking about health systems navigation or the logistics of moving, one of our participants said, quote, "I actually wasn't able to get my prescription fulfilled at the pharmacy in my new state. I had to cross state lines to get it there. My doctor was calling across all pharmacies and no one had PrEP." This is something around geography, which comes up a lot. People talked about living in an urban intercity space versus a rural reservation space and their need to go back and forth. And in this particular case, someone had gone in, had the conversations about PrEP. They said, yep, let's write a prescription, but they couldn't find a pharmacy to fill it. And so it took a little while for that to get sorted out. They were, I will report, they were able to get the prescription filled and maintain it over time. But this was, something that they had experienced where they had this kind of delays in waiting because the infrastructure of getting medicine dispersed to where, in this case, Native people live, took a while to figure out. And this was again in 2020. Next slide, please. This idea about PrEP buddies, I'm not sure we're going to keep calling it that, but it kind of came up several times where people found community within others who were on PrEP. And this makes sense. When you experience stigma or the idea of stigma around taking a medication for all the reasons we mentioned at the beginning of the talk, finding someone who is in a similar situation as you, where you can rely on them in terms of a social support or find a quote unquote PrEP buddy, makes sense. So this participant said, quote, I'm just talking, and somebody else was like, I'm on PrEP, and I was like, oh, how's that going? And the accountability in the community within taking PrEP has really helped me too. Because at the beginning, you had heard a lot about people being shamed. So again, finding camaraderie or community within and amongst other Native folks who are taking PrEP seemed to be very beneficial for this particular person. Next slide, please. Again, on the same theme of PrEP buddies, this participant said, quote, I think it's always been important for me to have that sort of community, whether we're talking about PrEP or something else. My other gay friends were like, you're not on PrEP yet? You should get on it. Like, not like shaming or anything, but it was almost like the opposite. And soon we were like PrEP buddies, we were so accountable for each other. Next slide, please. And so, finding someone to be in community with, to hold accountable with, this idea of being in community was very strong, but it also led to strong discussions and themes that came up within the interviews around PrEP use as advocacy. And so this participant said, quote, the doctor says, what do you need me to do today? And I say, I'm here for my labs and prescription refills. He'll say, well, I guess it's time to check those pesky STDs. He goes, I take it that you're still sexually active? And I go, oh yeah. And he kind of looks at me because of my age. And I say, do you still think you need that? And I go, yes, I still need it. I'm sexually active. And he looks at me like maybe I'm not that sexually active, or maybe I'm too old for that. And this particular interview was great in the fact that this person had been on PrEP and had gotten off of it, again, for other reasons outside of their control, and then had been on it for quite some time. But this was the person who I had the initial quote of before. So this person is much older, and by that I mean older than myself, and was the one who was really kind of, really afraid of HIV early on in their life. And it's been taken kind of this notion of using advocacy and self-advocacy specifically to take control over the fear of HIV and kind of the mental anguish that it might have caused and that kind of thing. So this is someone who's going in, I would say this person's probably in their mid 60s, to really say, this is what I need, and really to advocate for them, even when in this case, the provider or the system is advocating for them to not be on it, or stereotyping them to be something else than what they really are. Next slide, please. Oh, it is the closing slide. So in closing, a couple of other quotes that have come up. One participant said, getting on PrEP, staying on PrEP, and continually using PrEP as a way of to advocate for PrEP use. So this individual was really, PrEP is very important for them. They do a lot of work in advocating for other Native people to be on PrEP in their spare time. But one of the things that they really took to heart was that they also needed to get on PrEP for their own individual sake, but also for the sake of advocating for it. A different participant indicated that PrEP is a practice of protecting myself, protecting others, and protecting our community. And so in closing, to kind of sum up the preliminary findings of this particular project, PrEP initiation and sustained use relies on understanding personal and community risks, as well as resilience in the form of self-advocacy, relationships with informed and trusted providers and systems, and moving past stigma and shame. With that, my email is there. I'll also put it in the chat if you want to take this down so we can maybe have some time for questions or discussion. But thank you very much.